National Hospital, Kandy. Charith. Sorry, you start.
Good morning, everyone. Last week, I also attended the PowerPoint presentation and learn a lot, and I got a competency certificate as well as a group work. So when it come to the individual, I thought my hidden talent will be hidden, and I'm just using my conventional way of PowerPoint presentation. So my topic is so common, but so far the diagnostic dilemmas in fungal infection. Basically, I'm going to discuss two cases which I think very important in these days because I have only came to Kandy Hospital 2.5 months ago, but I have seen many fungal infections. I mean, one of the commonest fungal infection I have seen is mucormycosis. So these cases are based on the mucormycosis cases I have seen. Before coming here, I was in Purunegala, and I have to say, per week I have seen about 1 or 2 cases of mucormycosis cases, and the diagnosis and the treatment is very challenging, which I will explain why they are very challenging. The treatment. So this is a 75-year-old male patient coming with uncontrolled diabetes mellitus, and his presenting complaints were fever, cold for 10 days, and he had a very severe toothache. And later he presented with a nasal bleeding. Apart from that, this patient had progressive numbness and severe pain in right face, a right frontal headache with difficulty in opening mouth. So on clinical examination, there was a marked periorbital swelling and a very discharge was coming through the nose. So the patient was admitted to the hospital, and initially he was managed in many wards, and later the patient was referred to the ENT ward and antral washout was carried out. His blood parameters were, he had a white cell count of 16,000 with a neutrophil predominant, and CRP was 185. So when the antral washout was done from the ENT unit, the samples were taken and the samples were sent for histopathology as well as for microbiology. And when a fungal infection is suspected, especially a mucormycosis is suspected, there are some simple tests we can perform at the laboratory. One is the direct smear, which is very important. And when we perform the direct smear, actually in the direct smear, to the right of your side, as slide shows you, you can see fungal filaments. So if you see fungal filaments in a direct smear, it is a very significant finding. And then we proceed with the cultures, and about 2 days later we group the fungal agent, which is one of the causative agent for mucormycosis. So the diagnosis was made and the information was given to the ENT surgeon, and luckily extensive debridement was performed from the ENT section, and even at that time the drug of choice is liposomal amphotericin, and it was available in the hospital, and he was treated with adequately and patient survived. And this is my second case. This is a 63-year-old patient, again a non-diabetic and uncontrolled. This patient came with fever for 1 month, cold and cough, and right facial pain with retroorbital swelling for 2 weeks. And patient has complained burning sensation in nose. And again, the white cell count are the same. It is suggestive, it is similar to a bacterial infection. High cell count with a neutrophil predominant, and the CRP was fairly high, which is 82. And again, same story, and the patient was transferred to a ENT unit, and they suspected an invasive fungal infection, and the antral washout was performed, and we received the samples. As I discussed in the earlier case, in the direct smear also, we have seen the fungal hyphae, and we were able to grow the organisms as well. So the final definitive diagnosis was reached as mucormycosis, and like the other case, the same management was carried out, that is extensive debridement with a treatment with adequate dose of liposomal amphotericin, and luckily this patient also survived without any comorbidities. Right, those were the two cases, and I will briefly discuss about mucormycosis. And during the latter stage of the presentation, Senior Registrar from Histopathology section will discuss his part, the role of histopathologists in diagnosis of mucormycosis. So before that, I will give a brief introduction about mucormycosis. So what is mucormycosis? I think the name mucormycosis came into the light during COVID-19 pandemic, and you all are aware, in India we have seen a lot of cases of black fungus associated with COVID-19 cases. Even in Sri Lanka we have seen few cases. So basically the mucormycosis is the scientific term, a scientific definition for this black fungus. So it is an aggressive angio-invasive fungal infection, and in textbooks it says it is so common in severely immunocompromised patients and in severely hypoglycemic patients. But the extensive research on this matter is very, very minimal, because in tropical countries, with my clinical experience, I think this is so common, and it is very, very common in diabetic patients, especially when their diabetes is not under control. Epidemiology, it is a ubiquitous fungus. You can get them in many organic substrates like fruits, vegetable matter, soil, animal and excreta, and my personal experience is it is very, very common in hay. So being an agricultural country, I mean, in my opinion, it is not uncommon in Sri Lanka, and mainly you get the disease or you get the spores via inhalation. Causative agents, I mean, there are a lot of fungus which falls under this group, but their histopathological or the microbiological features are more or less the same, and the clinical presentation is also the same. So name a few. There are species called Rhizopus, Mucor, Cunningamella, Succinia, and Rhizomucor. So as I said before, the extensive studies hasn't been done in Sri Lanka. So which one are the predominant? Actually, we don't know. But the most important thing is, from a microbiological diagnosis or the histopathological diagnosis, if we can come to a conclusion as a mucormycosis, the treatment is the same. So as obvious, there is a seasonal variation, and as I said before, exact incidence is unknown. Even the exact pathogenesis is unknown, but it is regarded as one of the invasive, angio-invasive fungal infection. The other important thing is the clinical presentation. It is described, the main clinical presentation of mucormycosis is rhinocerebral, and under rhinocerebral there can be subtle variations of rhinocerebral infection. Apart from that, you can get pulmonary mucormycosis, which is common in neutropenic patients, and also you can get gastrointestinal mucormycosis, especially in premature neonates, and also you can get skin and soft tissue necrosis, especially in burn patients and extensive trauma patients. So the rhinocerebral infection is the commonest one, and to be frank with you, this is the most the common presentation I have seen. There are subtle changes. Some are rhinosinusitis, so basically they are confined to the sinus and the nose, but some are rhinoorbital and also rhinocerebral. With my experience, I have seen the upper two clinical presentations, that is rhinosinusitis and rhinoorbital. And as I described before, mainly the rhinocerebral infections we are getting due to inhalation. So the diagnosis and the treatment, So basically the most important thing is you need to do a antral washout and you need to send it for culture and also for histopathology. So the diagnosis can be, I mean, you can diagnose it microbiologically or sometimes histopathologically. So we are conducting this symposium to show you how important the clinical departments working uh, cooperatively with the laboratory, and also the laboratory, we have different sections, so our cooperation is also very important when we need to come for a definitive diagnosis, because sometimes in the microbiologically we can't grow, we are not going to see the causative agents, but in histopathologically we can get the diagnosis. So I mean, the histopathology senior registrar will discuss the histological part. I mean, in the tissues, you can easily differentiate this fungus from the other fungi, and he will describe its features in his lecture. And the treatment, there are a few important points. The first important thing is the timely diagnosis. So I have seen several patients actually, they are coming very late. One of the common presentations, as I described before, they are coming to a dentist, an uncontrolled diabetic patient coming to a dentist with toothache. So basically, I mean, if you when they come for a dental doctor, I mean, it's quite easy to find out a very bad tooth. So they are subjected to tooth extractions because they think the toothache is related to the dental caries. But if a patient coming with uncontrolled diabetic with a facial swelling, with a teeth ache, please think about mucormycosis. So because the timely diagnosis is very, very important. It is not very rapidly spreading. So if you can timely diagnose the patient, you can save his eyes, because the infection is usually, the rhinocerebral infections are usually originate in the sinuses, but they are slowly and progressively spreading to the eyes. I have seen, because of the late presentations, actually at the time of their presentation, they have lost vision of one eye. And other most important thing is the reversal of underlying predisposing factors. And the other most important thing is in these clinical scenarios, I think the main the most important unit is the ENT section, because you need a rapid debridement and then the effective antifungal treatment with liposomal amphotericin. So what are the challenges of the treatment? The first important thing is we should get aware about this disease. This is there because it is very important to get a timely diagnosis. So the patient can present to a general practitioner, a dentist, or physician, or ENT surgeon. So if a patient coming with facial swelling and a toothache, I mean extensively in an uncontrolled diabetic patient, you have to think about mucormycosis. So the challenges, we need to, I mean, educate doctors and the public that this disease is there. And the second most the challenging part at this juncture is, as I said before, the most important thing is the extensive debridement, and then we need to follow up with liposomal amphotericin. But unfortunately, liposomal amphotericin are very, very expensive. So earlier it was around 15,000 a vial. A patient need about 3 vials per day. So now the cost of vial would be, it is around 60,000. So you need to treat this patient at least for about 14 days. So you can calculate how much money you need to treat this patient. And even if you are going to get the disease, I don't think even we are going to afford that amount of money. So these days actually we are diagnosing patients, but unfortunately we are helpless when it comes to the treatment. So I have seen few patients actually who are dying slowly because the drug is not available in the MSD. So even much cheaper drugs are not available in the hospital these days. So it is a nightmare sometimes to treat. But luckily, at this moment, we have some vials in the hospital as well as in the MSD. So that is the most challenging part of the treatment of these patients. And other most important thing is we need to control the diabetes very extensively. And with the shortage of even this hyperglycemic drug, I think in the community, I think the sugar control must be very poor these days. So I think we are going to see a lot of patients in near future due to shortage of these essential drugs. Thank you very much. Now I will hand over the lecture to Senior Registrar in Histopathology just to brief you about histopathological diagnosis of mucormycosis. Thank you.
Okay. Good morning. I will be discussing the fungal infections in histopathology. Histopathology can be used to diagnose the fungal infections if the fungus can be identified in tissue sections. But for that, we need knowledge about the fungal morphology as well as the various tissue reaction patterns as response to the fungal infections. So, when we considering the morphological parameters, the important such features are what is the predominant form of fungus, whether it's yeast, hyphae, or pseudohyphae, the presence or absence of capsule, thickness of the capsule, the pattern of budding, whether it's a single or multiple, or it's a narrow based or wide based, and also the presence or absence of septae and branching pattern. When considering the tissue reactions, there are various patterns in histology. The commonest is the neutrophil abscess formation and suppurative inflammation. And there can be necrosis. It may be due to the ongoing inflammation or due to the infarction of tissue as a result of vascular invasion by fungi. And there can be cases necrosis in some fungal infections mimicking the tuberculosis. And there can be a deposition of amorphous eosinophilic hyaline material around the fungi, which known as a Sprender-Hopley phenomenon. Then we will see what is the importance of stain. Usually in routine histopathology, we use hematoxylin and eosin stain, and it stains some fungi, but most often it's not adequate, and we need other special stains. But the importance of herein stain is it will highlight or it demonstrate that tissue reaction patterns that I mentioned earlier. So it will give a clue to pathologists for go for other special stains. So the two important special stains are Komori methylamine silver stain and the PS stain. The silver stain will highlight fungi in black to brown color. The PS stain will highlight fungi in magenta color. Other than that, the mucormycosis and Alcian blue stains will highlight the capsule of the Cryptococcus. Then we can broadly classify the fungal infections into superficial mycosis, cutaneous mycosis, subcutaneous mycosis, and systemic infections, depending on the site and the extent of the infection. Among those, the systemic mycosis is the most important group in the clinical point of view. The systemic or disseminated mycosis is usually seen as opportunistic infection, and the high risk groups include the immunocompromised patients, the patients who are on long-term steroid, HIV/AIDS patients, hematological malignancy, etc. So I will go through several important fungal infections that can cause systemic mycosis. The mucormycosis is such fungus. The mucormycosis can be visualized in the Chinese stains and also the special stains like Grocott. The first two images from the Chinese stains. third one is the Grocott stain, the silver stain. There are few important morphological patterns that we can identify that help to identify this fungi. Usually the hyphae are broad in this fungi, and there are no septae inside this hyphae, and the hyphae branching in right angles, and it also cause not to cause vascular invasion and tissue destruction. Then aspergillus is another fungus that can cause systemic infection. When you compare to the mucormycosis, the hyphae are narrow, and there are multiple septae inside this fungal hyphae, and they are branching in acute angles. So that second picture is the silver stain, which highlights the fungus. Then Candida also can cause systemic infections. Usually appear as oval budding yeast. Sometimes it may show pseudohyphae formation due to the budding chains of budding. It can stain as well as in Grocott stain, but more clearly seen in Grocott stain. The Cryptococcosis is another fungus that cause systemic mycosis. It only present in yeast forms with narrow yeast budding. The characteristic feature is it has a thick gelatinous capsule, and it is can be stained with Alcian blue and mucocarmine special stains. That second image is a mucocarmine stain. In that image you can see the small purple color ring around this hyphae that's stained with mucocarmine. The histoplasma is another fungi that can cause systemic infection and commonly present as an intracellular thin wall yeast. The first image is a H&E section that we can see within the macrophages, small tiny yeast forms, and but the Grocott stain highlights this fungi very clearly. The blastomycosis is also present as a yeast form. There's a thick double contoured cell wall with visible multiple nuclei within this yeast. So basically, so the important take-home message is the histopathology can be used to diagnose fungal infections, and also we can give other important information such as presence or absence of vascular invasion and tissue destruction. Thank you.
Thank you, Muditha and Charith. Any questions in this case?
I couldn't elaborate on that one, but it is when we are treating with liposomal potassium, then actually we need to measure potassium regularly. So it is a known fact. While treating with liposomal potassium, your potassium can go down. But actually, yeah, I didn't notice it actually.
Okay, thank you very much.